Thank you.
Whenever
Thank
you
you.
want.
Welcome.
This is what I understood. Yes, thank you very much. Dear colleagues, it's a great pleasure to be here, and this is my second Spanish Congress, and I really enjoyed. So my topic today is to give you an overview of current therapeutic algorithm on cutaneous lupus erythematosus. Those are the definitions that I usually like to present when there are some rheumatologists, if they forget that lupus started and was discovered by dermatologists. These are our small fights. I'm looking at you because I know that now we are better and better. What we can see also from few recent publications, we speak about very big importance of good cooperation of dermatologists and rheumatologists for well-being of us and of our patients. Sorry. So this is the classification that is generally used, but if we go more specific in cutaneous manifestations, there was a first classification done by Gillian in 1977, and the one that was published in, I think, first time in 2003 by Annegret Kuhn, so-called Düsseldorf classification, which is dealing with cutaneous manifestations only. But when we speak about treatment, it is always very optimistic when you start reading some references, and then one of the first sentences is there is no approved drug specifically for the treatment of cutaneous lupus erythematosus, and we can sometimes feel it in our patients because we know, although we have some drugs, and we are using most drugs off-label, that about 10% of our patients are refractory to all available recommended therapy. So regarding guidelines, there are one old European guidelines that were published in 2017 and that are very, very ready to be renewed. The one a little bit more new ones are German from 2021, and in the same year, British guidelines were published. So when we speak about guidelines, we most commonly use this EULAR for non-renal affected patients. But here is a table that I would like just to show you which drugs are FDA or EMA approved for the treatment of cutaneous lupus erythematosus, and those are steroids, antimalarials, and nothing else is approved. We speak about the approval. So when we look at the most recent published guidelines, and those are EULAR guidelines, which are for treatment of non-renal systemic lupus, there is a big part dealing with the skin. So in the next slides, I will go through the points that were mentioned in those guidelines as well as some previously published. First is prevention. What we sometimes forget to tell patients, or we tell patients, but patients don't listen because for them it's a little bit too basic when you tell them to use sun protection. But we should maybe continue in speaking about that and continue to pointing out how important it is. I know that some countries which can afford it give patients the sunscreen creams paid by the insurance companies, because when they made cost benefit, then they discovered that patients only use it when they have enough and they don't have pay. Of course, vitamin D supplementation and smoking, stop smoking, because there are facts that about 70% of patients with any kind of lupus are smokers, and this is something that is well connected. So if we go speak about topical treatment, topical corticosteroids, high potency would be first-line therapy, if possible in like ointment, not a cream, because cream could be a potential trigger of irritation. Then calcineurin inhibitors and retinoids, which I personally don't use very often, or I can better say I don't use it for the patients with lupus, although I know some of my colleagues do it. Regarding systemic treatment, antimalarials are still first-line treatment. I would say that most of us today use hydroxychloroquine, but there were some discussions in recent years about the dosing. There were questions, should we give real body weight or or ideal body weight. Then we can discuss what is ideal body weight. So we came back to real body weight. But I also have to say from the practice that we usually use the dosage of the tablets that we have available, so we adapt it to the available drugs. So regarding ophthalmological evaluation, there are also some discussions. It is written in most of the guidelines that control should be done after 5 years, and we usually teach that students and residents. But if I look system of my hospital, of my department, then I see that my doctors are doing that every year. So one is theory and the other thing is practice. So regarding hydroxychloroquine, it raised a little bit of more interest when COVID started, because I don't know if it happened here, but in Croatia, we read a lot about that hydroxychloroquine will be drug that will solve all the problems. And in one moment I had my table some boxes of hydroxychloroquine, because they told me keep it aside because we don't know, we will maybe need it. But of course we learned that it was not like that. We know that for lupus it is useful. It also correlated with reduction in interferon alpha levels, what is part of pathophysiology of lupus. And also it has some other metabolic benefits, including improvement of lipid profiles and lowering blood glucose levels. But pharmacological properties regarding pharmacological properties, it's known that elimination is 40 to 50 days, and drug reaches 95% of steady state after about 6 months. Why I'm telling that? Because evaluation of the treatment shouldn't be done earlier than 3 months and within 3rd and 6th month of the therapy, because if we do it very early, then we can maybe stop the drug, which could be efficient after these 3 months. But what happened with this hydroxychloroquine and COVID? It raised interest, and some publications were available on internet, which were read by our colleagues, by our peers, and also by our patients. And also this raised concerns, is that drug also may be dangerous for the lupus patients? There were a lot of questions. And some of patients also stopped taking drugs. And there was also before COVID, but especially after COVID, big French study where they studied blood levels of hydroxychloroquine and chloroquine. And after that, another recommendation was introduced in all guidelines that before changing drug, before stopping hydroxychloroquine, blood level of hydroxychloroquine should be done, because a result of this big study was that 50% of patients are not taking hydroxychloroquine in the dosage they were recommended, or they are not taking it at all. With systemic corticosteroids, we know it can be additional first-line treatment, but we try to taper the dose or discontinue as soon as possible. Regarding thalidomide, it is second-line treatment. It is a drug that has its story, but I have experience in 10 patients, and it is a drug that really helped a lot our patients. 2 of my patients had peripheral neuropathy, but they were still ready to have these problems, but have improvement in their lupus. So some of them really stayed on thalidomide. Today, we also have in this ladder of different therapies lenalidomide, which I personally don't use because we don't have this drug available in Croatia. And there are some new studies on iberdomide. Quite recently, it was published by Vicky Wirth in JAAD, results of the randomized phase 2 clinical study on iberdomide, where the results are still a little bit questionable, because there are some improvements in CLASI response, but not so good, of course, in chronic lesions on the skin. So as we have some other drugs in the pipeline, I'm not sure that this drug will have good and long life. Regarding methotrexate, it can be used in some patients as second-line treatment, primarily in subacute cutaneous lupus erythematosus. Mycophenolate mofetil is third-line treatment. I don't know the situation in Spain, but we have this drug on the list just for transplant patients, so we don't use it usually for the patients with lupus. Retinoids are something that can be used in some specific cases of lupus, like hyperkeratotic, or Dapsone can be used for bullous lupus erythematosus according to guidelines, but my experience with those drugs in lupus is not very high. So there are some novel therapies which I have to say are quite promising. In the first place, anifrolumab, litifilimab, and some other drugs, which I will touch here shortly. And when I started preparing this lecture, wanted to add a few slides, I was really nicely surprised that I found 2 references from Valencia, quite recent references with good experience, and I really read it with big interest, which are giving some positive results from the one is review, which reviewed the publications, and in 20 publications there was a report of 78 patients, and it was published in 2024. Till now there are some more, but still not very many of them. So, and the results that were presented in the other study that I found, and this is quite recent, from 8th of April, really we can see very good results of anifrolumab to the cutaneous lesions of lupus erythematosus. I have 4 patients which are treated by our rheumatologists, because we are not allowed to prescribe the drug, but rheumatologists are prescribing drug to the patients, but we have good relationships, so we don't have big problems. And results are really, I have to say, impressive. I know that it's currently study ongoing just for cutaneous lupus erythematosus for anifrolumab, and I hope we will have also soon this drug available, and soon available also in our guidelines, because without, I don't say that we need guidelines to use something, but our politicians love to ask, when we ask something to be put on the list, they ask, is that in the guidelines? So that is the reason why we need guidelines. There are also a study that is ongoing on litifilimab for cutaneous lupus erythematosus, and if you look on the webpage of the study, currently is a study ongoing, this Amethyst study, phase 2, phase 3 study, and there are some also promising results with that drug. So I think that there are also some promising results with deucravacitinib, and that is the reason why I think there is a good future for our lupus patients, which for a long time have been really suffering of severe disease, especially patients with discoid lupus erythematosus, and we were not able to offer them some good therapeutic options. So there are, of course, some JAK inhibitors. I'm not a big fan, because I have a feeling that JAK inhibitors today are, I hope there is nobody from industry treating everything like panacea, but yeah, there are some good options, especially this ruxolitinib cream. I had a colleague who ordered herself that drug, and some results were really very good, but I don't have my personal experience. I have seen just that patient, but there is a study on 10 patients with discoid lupus erythematosus, with activity was improved, and of course damage not, because for improving damage, classy damage, there is much longer time needed to see anything like that. So at the end, I would say that speaking about guidelines, we need guidelines, but of course experience is very important. Maybe as I'm getting older, I see much bigger importance of this little bit of not only evidence, but eminence-based medicine, but comes maybe with age. But above all, teamwork is very important, and possibility to exchange our experience here, or I will misuse a little bit this podium to invite you also to our spring symposium, which will be very soon in Prague, or to our Congress in Paris. I expect to see you all there. Thank you very much.